have Dr. Michael Weinstock. He is a professor, and every time I hear the word risk management, his face pops up in the back of my mind. If you haven't read the Bounce Back books, he's the author of them. They are very good and put like a healthy scare in you when you walk into your patient's room. And it's the reason I ask myself every time I walk into patients' rooms, like, how am I going to kill this patient? Like, what am I going to miss? What can I document? And how can I make sure this patient doesn't bounce back? Michael's also published numerous times, spoke a lot on many different platforms. He is the CME and IRB chair at Adena Medical Center in Ohio. It's very cold right now, I guess. Also on Corpendium, EM Rep, he does a lot of the risk management. And so he is gonna speak to us today about pulmonary embolisms and how to not get sued from that standpoint. Michael Weinstock, welcome, and please go ahead.
Thank you, Lean, so much. And thanks for the invitation to this fantastic conference with these amazing speakers. So I hope I'll be true to the next 30, 40 minutes of all of your time. And I want to just sort of really look back on my own sort of training. When I was a medical student at Ohio State, the Ohio State University, I remember that the professor that was talking to us about chest pain said, if you think about PE, you should test for it. And even at the time, I thought, boy, that just doesn't really sound right, because we see so many patients with chest pain. And really, as I've gone through my career, I've thought to myself, it isn't right, because the fact is we should always be thinking about PE with every patient with chest pain. But oftentimes now, especially with the help of the Perk Rule, we can exclude that at the bedside. So when you think about chest pain, of course, you know, the big three, ACS, PE, and dissection that George did a great job talking about earlier today, we should always be thinking about those. But it's astounding to me how infrequently in the history, which is really almost 90% of the time how we're going to get our diagnosis, or at least very much narrow it down to a few different possibilities. It's astounding to me, not only looking at charts when I'm, you know, work in the ED and I like look at the previous record from the patient, but also with medical legal cases. It's astounding to me, and I'm sure the other speakers would agree, how frequently in cases where there was a misdiagnosis, there was a poor history done, where the important aspects of the history were not adequately included. So that's really going to be our main first teaching point, is that the history of present illness always needs to be the history of present illness. And it's fine to put all those other things in your history. It's fine to put the past history in there, the review of systems, social history, all those things. And I do that also. But you have to actually have the history of present illness. And George talked about the old car mnemonic. I'm guessing that as we go through our careers, we focus that towards the things that seem important. But when you think about things like ACS and those big three causes of chest pain, we think about things like exertional pain, diaphoresis, radiation, or vomiting that Amal talks about all the time. I'll add a fifth one in there from a study by Farinoff, which is pain similar to a past MI. But then we move to the next one, because we're going to start with, I mean, most patients, the question that their presentation is asking, am I having a heart attack? But to us, not only heart attack, right, ACS, but PE, dissection, are also those other possibilities. So how can we have a patient where we don't even ask those first few questions, and also don't even go through things further, the acuity of the onset, if the pain is pleuritic, if the pain has been worse with exertion, for example, or if there's other associated symptoms, such as symptoms of unilateral leg pain or swelling, or any objective findings of that. So in the context of all of that, I wanted to just briefly describe our problem. And this is always our problem with every patient that we see, and that's the balance, right? It's the balance between over-testing and risking potential false positives, expense, maybe nosocomial infections for patients that are admitted that don't need to be, and the risk of missing serious disease, right? So we're always thinking about that. And we're going to really delve into that question as we go through things today. I wanted to, before I just give a brief outline of what we're going to be talking about, show you the first thing that came up on my web search of symptoms of pulmonary embolism. And some of those are obvious to us, as well as obvious to my neighbor, who is not a doctor, PA or NP, right, is shortness of breath, right, as well as chest pain. But the problem comes in sometimes when there's these other associated or atypical type symptoms, such as symptoms of anxiety, maybe a patient that has a lone cough, or maybe it's a patient who presents with one thing and has other symptoms that go along with it. In other words, some of these could be associated symptoms, for example, the anxiety. And I had, this is a few years ago, a nurse came out with a eye roll about a patient who was there and was just anxious. And after I saw the patient and then subsequently diagnosed the PE, I didn't say this to the nurse, but I thought it to myself, is I agree that they're anxious. I agree with you that they're anxious, but that's because they're dying, right? Which is a very anxiety provoking situation. So it's really important to think about some of those things, not confusing a medical disease with a psychiatric type symptom like anxiety or palpitations. And we're going to see some real cases here where that was done and the unfortunate legal implications of that. So in the context of all that, what I'm going to talk about here are some of the legal aspects of patients that present with PE, who is most likely to be sued, what are the common reasons that we're sued, as well as what are some of the red flags that we could pick up on and would cause us hopefully to be more cautious about that. Secondly, I'm going to give you some tips for documentation. I'm going to give 3 different examples of that. And hopefully those are things that we can take to the bedside when we're seeing a patient that has potentially a PE and maybe even potentially just a atypical symptom, and some specific tips that we can all use. We're going to look at some specific cases that went to trial and went to legal action and the outcomes of the patient's presentation, as well as the outcome of the legal action. And then I'm going to give some of the my own sort of, insights from the many legal cases that I've done, many of which have been PE, which is really one of the very frequent causes of the cases that I've seen. It's a pretty common one. There's some things that are pretty rare, and aortic dissection is certainly one. Missed ACS can certainly be one. Study by Brown looked at that and said that that's one of the more common causes, but certainly patients with PE are one of the more frequent ones that I see. Okay, so in the context of all that, there's a study by Wilson that just came out several years ago, and they looked at 277 cases that went to malpractice action involving missed PE or DVTs. And unfortunately, emergency physicians are the second most commonly sued group. Now, there are other cases, and some of the cases as part of their data set were cases of patients that had actually seen the surgeon, hadn't been prescribed anticoagulation, had seen primary care. But certainly as emergency physicians, it's a pretty frequent and second most frequent of all the providers who were sued. And no big surprise here, but failure to diagnose and treat was over 60% of the time the reason for the lawsuit. Now, failure to diagnose was the biggest part of that, but failure to treat is another part of that also. I'm going to talk about that in just a second, as well as talk about one of the more, not necessarily diagnostic dilemma, and especially or necessarily, but patients who present with PE arrest. Okay, so with this study by Wilson, the most common etiology of the PE was prior surgery, 41% of the time, as well as previous orthopedic trauma. So getting back to my thought on the history, unless we get that as a history, we're not going to really know it. So I'm not the guy, I have to say, maybe in a little self-deprecating way, who goes over every single medication with a patient when they come in. I'm especially, the squad from the nursing home with the 20 different medications, right? However, if it's a patient that had a head trauma, I'm always asking about anticoagulation. And in that same way, in patients with chest pain, one strong teaching point would be to think about if they have had a prior surgery, usually in the last 4 weeks, and then to really move PE up on a differential. Now, that doesn't necessarily mean that we need to do testing up front with that, but it does mean that we need to consider that and at least have a certain number of questions to it, because frequently, again, and repeating myself, a little bit of a broken record alert, is that I oftentimes see a few questions as to ACS, but sometimes one or maybe even no questions, even directed towards PE. And that patient's presentations question that they're asking us when they come with chest pain is not just, am I having a heart attack, but I'm also, am I having PE or dissection? Or we could even, extend it to cardiac tamponade or tension pneumothorax Boerhaave syndrome. But certainly these big three are things that we need to think about. With the cases in this Wilson study, they found that 57% of the time that went for the defense and 27% for the plaintiff, which is actually a little bit higher than you'll see in all comers. Usually, if it goes to trial, 85 to 90% of the time, it's going to go for the defense. But to quote one of the previous emergency medicine medical legal gurus, that true malpractice is settled. So if you get to the point of a trial, there's at least probably an argument on one side or the other. Huge range also in the payments for this, between $40,000 and $46 million for this. So I think without further ado, it would be really impossible to have this discussion without looking at the Perk Roll by Jeff Klein. And this was the screenshot of the initial study that he did in the publication in 2004. And some questions that I wanted to ask about the Perk Roll. So we've got to sort of think about these questions just a little bit as we're going through this. The first question is, does anybody here feel that they would be very comfortable during one of their department meetings or in front of their peers of saying all the elements of the Perk Rule? So that'd be the first question I'd ask all of us. I'm guessing the answer and lectures that I've done is very few people really feel totally comfortable just off the top of their head saying all that. Second question I'd ask is, our normal heart rate is 60 to 100, right? But is a heart rate of 100, does that make you Perk negative, or are you not Perk negative with that? The next question I'm sort of wondering about is, can we document Perk negative? Because it would certainly save time, especially if we were thinking about the Perk Rule in a patient who has chest pain who might have a PE. And then finally, is there such a thing as Perk positive? So addressing some of those things, I'm just going to put up the screenshot of the MD Calc algorithm here. And these are the components of the Perk Rule. Now, a lot of this is predicated on our pretest probability and our own gestalt. Now that is subject, and that's fine, subject to all of our own risk and all of our own experience. So I think people that have been doing things for a while, they might find that, a patient with maybe one symptom is low risk in their estimation, whereas someone else, even if there's one, would feel like that is too high and their own risk tolerance would be lower than that, and they'd want to get some further testing. But we have to be careful, obviously, rolling the roulette wheel with our D-dimer roulette, right? Because not only potentially could cause harm to a patient with radiation or contrast, if you believe in that, right, nephropathy, but in addition to that, also there's a huge amount of expense, there's time, and there's, most importantly, probably the risk of false positive, which could be up to 5% with patients with a CTA. So if you look at this, a heart rate of 100 was actually not able to be called Perk negative. So that's a subtlety that it's important that we know about. And a heart rate of 100 or over anytime during their ED course also is not able to categorize them as being Perk negative. So thinking about just putting that documentation, we're going to talk about some other specifics of documentation in a few minutes, but putting those specifics of documentation down, saying just Perk negative because we think we're saving time, that's okay, but you got to be really sure that the patient is Perk negative. Because if you do that and you use that as one of your rationale for sending home a patient who later is found to have a pulmonary embolism and they weren't Perk negative, that's going to be very devastating to your defense. Much better to list those elements. And honestly, for me, I'd have to say, even after all these years, right? If I have a patient with syncope, I am putting on my EKG interpretation, normal sinus rhythm with a rate of 65, without ischemic changes, and no Brugada, WPW, hypertrophic cardiomyopathy, prolonged QT. I'm doing that, sort of keeps me honest. And I find in the same way, I can do a macro or I can say Perk negative, but it does keep me honest to say those specific elements of the Perk Rule that I have asked the patient and to make sure that those are actually accurate. So that's a very, very important first teaching point with documentation. All right, who's this guy, right? So this is a couple of years ago. no big HIPAA disclaimer on myself. I'm 57. I was 55 at the time here. But the bottom line is there's no Perk positive, because in this picture, after climbing to the top of Piton in St. Lucia for many thousands of feet and almost having a heart attack myself, right? The fact is, I was not Perk positive at that time, right? So there's no Perk positive, and there still is a rule. There still is a role for thinking of the Perk rule in patients that we are evaluating, even if we know that we can't rule them out with Perk, because it's still a combination of all these things. And George, I hope you don't mind me continuing to quote you from that fantastic lecture that you gave. But combining a lot of these things can be super helpful for us to do. So if you have just one thing, for example, their status okay, or they're not tachycardic or not tachypnic, all that stuff is fine. But combining all of these things in a patient we know we can't rule out with the Perk rule, but having all those other criteria will be a rationale in our medical decision-making note to justify why we send home a patient who is not Perk negative. Okay, so going to some of these other things further, we just talked about how a patient really shouldn't have, I don't think anyway, unless you're super sure of yourself, and that's fine then, the documentation of Perk negative, but brings up the next question. Can I get sued for a PE after applying the Perk rule? So going back, and I'll use the screen in respect to all the people who don't look at my image any more than they have to. If you look at the bottom here, 0 criteria, there's less than a 2% chance of PE. Well, that's really curious. And when you think about that, and we look at a study by Than, as well as a study that I've done myself on an acceptable miss rate for MACE for ACS, we found, as well as a study by Than, that less than half the people were comfortable with a miss rate of MACE of 1 or 2% for ACS. But we're saying here with pulmonary embolism, well, less than 2%, is that okay? Now, I will say, really great news, and with the ACEP guidelines for ACS in 2018, for the first time established an acceptable miss rate. So a lot of people, I think, have read this already, but ACEP established a miss rate of 1 or 2% for missed ACS, and they specifically say in that 2018 document that the reason that we want to have a miss rate of that amount and not lower is because of the risk of false positive tests and extraneous testing, which would actually cause more harm than good. And the same way with PE. If we think about patients who have a possible PE of 1% or 0.5%, which might be higher than some of us would feel comfortable with, the risk of testing will be higher than the risk of missing the disease. So again, this is a balance also. I'm going to flash up on the screen a study that, this is actually an editorial that I did with both Amal and Eric Katz from the University of Alabama. And it talks about how we balance the long-term health of the patient with the short-term risk of the physician. And this is such an important concept for all of us. And the fact is, I feel comfortable with the fact that I'm going to take the best care of the patient, make sure that they know I'm taking the best care of them, and that will then roll back on the fact that we will have a less likelihood to be sued. So that might sound a bit Pollyannish, but I will say as a caveat, all of that in the context also of appropriate documentation and an explanation of our thought process of why we did what we did and why we didn't do other things, as well as the fact that when we are evaluating those patients, that doctor-patient relationship that Evie talked about is so, so, so important. And actually a study that I've quoted many times in the past, but a little background information on, a study by David Sklar from University of New Mexico, Annals of Emergency Medicine, when they looked at bounce back deaths. I was going to put bounce backs in the discussion here, right? So when they looked at bounce back deaths, defined as a death within 7 days after an ED visit, out of 380,000 patients that they looked at, they found 35. So 1 out of 10,000. But again, if we see 150 to 175,000 patients in our career, that's going to happen to each of us 15 to 17 times in our career. So when they looked at those patients, those 35 possible error cases of patients who died within 7 days of their ED visit, well, when they look back at those patients, not one of those patients sued their clinician. And my guess is the reason they didn't was because of that understanding, maybe with shared decision-making, maybe just with an explanation that the physician or the clinician was doing their best to care for that patient. Okay. So in the context of that, let's get into documentation just a little bit, because I want to give some specific stuff that we're all going to be able to use at the bedside when we're seeing patients with this. And shared decision-making is something that we've talked about a million times and many people have talked about. And frankly, I found in some ways just a little bit annoying in some ways. One of the ways is that people just use it willy-nilly, but also I think that sometimes we as clinicians abdicate our responsibility to the patient. And I see it, and Evie, I'm guessing that some of the things that you alluded to in your discussion, we see it sometimes also with the stroke neurologists. And I'm looking at this patient, I'm saying like, look, I get it, you're having some symptoms. I'm involving the stroke neurologist, just like Evie recommended. But look, there's no way this patient should get TPA. And I know the stroke neurologist agrees with that, but yet they're still offering it so they can put somewhere on their chart that they're engaging in the process of shared decision-making. So shared decision-making really needs to be a decision that's made between two reasonable alternative pathways. So one perfect example is giving Decadron for a headache, right? It doesn't help to stop the current headache, but it might prevent future headaches. And we think to ourselves, well, what's shared decision-making? Someone says, oh my gosh, last time I got prednisone for my poison ivy, I was awake for 3 days with insomnia. And someone else says, oh my gosh, I slept like a baby. I got prednisone last year. Yeah, I'll take the Decadron. So a reasonable decision between two pathways. And we're going to see with some of these documentation examples how we can put the patient's amount of risk tolerance in there, and we can see what their thought is with that. So putting that in our medical decision-making and specifically addressing if there's even a small possibility of PE in the same way that we do a stroke, where I might say something like, in a silly way, right? The patient is not a thrombolytic candidate because of a huge intracranial hemorrhage, right? So, we want to put on there why they're not a thrombolytic candidate. In the same way with someone that even could have the possibility is to talk about the fact that we are not testing for PE, but why we're not specifically testing. And not to take tons of extra time with all the patients that we're seeing, but if we see 7% of patients in the ED with chest pain, and I get it, there could be some with cough or shortness of breath or anxiety, palpitations, who actually have PE, but with all of those patients, we really want to think about that. There might be 2 or 3 patients where we take a little bit of extra time for it, but my contention is that it'll be well worth it to do it. Before I give those examples, I just want to talk about malpractice. And this is a very, very important concept, is that malpractice is not missing a diagnosis. And there can be a lot of ways that people think about malpractice. My own thought is that malpractice is 2 things: inappropriate data gathering and poor medical decision-making, sometimes because you don't have adequate data on which to base your decision. So really think about your history. I keep coming back to it. Again, broken record alert, because we need to have appropriate data on if this could be a PE, and then we need to make a reasonable decision based on that. And again, Perk Roll is fantastic, but you can't use it the way it was designed in patients that are over 50. So you can still use it, but you can't use it to rule out a patient based on the Perk Rule, but we still could rule out a patient based on our own medical decision-making. So let me give a few examples. And some people might feel uncomfortable or want to do things differently than I would in this situation. That's totally cool. But I would guess if I asked a first-year medical student or one of my kids or my neighbor, right, about a patient who's 19 years old, who's on oral contraceptives, who comes in with bloodstreak sputum, what is the question that their presentation is asking? And to me, as well as I'm guessing that medical student or my neighbor, the question that their presentation is asking is, am I having a pulmonary embolism? So why would I not? In fact, how could I not order further testing, objective testing, like, a dimer or CTA, right, to think about PE in that patient? Well, how about a documentation, something like this? The patient is 19 years old, and the medical decision-making. Patient is 19 years old. She has bloodstreak sputum, and she's on oral contraceptives. However, I feel that a PE is unlikely based on the fact that she has a temperature of 102, Her two siblings are in the room with similar infectious type symptoms. Her bloodstreak sputum started after a particularly vigorous episode of coughing, and she has no unilateral leg swelling, recent surgery, tachycardia, tachypnea, hypoxemia. That to me, and that I've engaged in a process of shared decision making where I told her about that. And that's going to be an important concept with the final teaching points here too, is to make sure that the patient understands the diagnosis that we have not definitively ruled out, but we feel is unlikely, and the risk of testing might be greater than the risk of missing the disease. So that's one example. How about a patient with COPD? There is some literature to suggest that patients that have COPD have a higher risk of PE. Well, a patient with COPD and shortness of breath, how about some documentation like this? 63-year-old man with COPD, shortness of breath, had a recent change in the color of their sputum from clear to green. They have a fever, they're short of breath, they have bilateral wheezing, and none of those other risks that we talked about with PE or other things, also obviously recent surgery or cancer, etc. I feel the risk of PE is very unlikely. We'll treat them for COPD with steroids, albuterol Atrovent plus my antibiotics, right? And they agree to return if their symptoms progress or worsen. So to me, that feels like a indication that we've thought about PE and we've discussed that, and the patient seems less likely to have that. And we could also, again, throw in shared decision-making with that too. How about a 23-year-old who has a history of asthma and shortness of breath? I had a patient like this recently who ran out of their inhaler. They came into the ED and I saw them. And when I examined that patient, they had no wheezing whatsoever. So this is a little bit of a different type of documentation. It's going to be very difficult to just put PE in your differential. And I've seen differentials in the charts that I've looked at have been 20 items long. But an important concept here, you don't really get partial credit in the ED for thinking of a diagnosis that actually turns out to be the diagnosis when you have done absolutely nothing to consider that diagnosis with any testing or treatment that you've done, or further data gathering with your history and physical, right? So you have a patient who has no wheezing whatsoever, no wheezing with forced expiration, but yet you're thinking, oh, well, it's just asthma because they have a history of asthma. I mean, look, if you're betting $5, maybe that's a good idea. But if you're seeing those patients in your career and those 150 to 175,000 patients you're seeing in your career, pretty unlikely that you're going to get away without missing a PE in that patient who you just think it's asthma with no wheezing whatsoever. That's going to be a very hard diagnosis to justify later. Okay, finishing our documentation part, and we'll get into a little bit more in just a few minutes here, but I don't in any way want this to be a allegation or a recommendation to practice defensive medicine. However, we do need to evaluate and document in a way that is defensible. So very briefly, as a little bit of a branch point, can we use a physical exam? And Amal and I together gave a lecture out in LA a couple of years ago, right before COVID started, on limitations of history and physical. And one of those limitations is patients with leg pain or swelling and our ability with our history. And in fact, if you use the Wells criteria and have a Wells criteria of 1, you still have a 17% chance of that being from a DVT. So for me, and maybe I'm over testing with this a little bit, but it feels like whichever evaluation you're doing for that, whether it's with a Doppler or a dimer, right, that if you have some lower extremity pain or swelling, you're going to need to get some objective testing to look for that. Okay. So what I want to do now is talk about some specific cases. And these are cases, there's 3 of them that went to legal action. We'll go through them sort of quickly and hopefully a little bit of time for questions and the wrap up points. But the first one is a 35-year-old man with chest pain, shortness of breath, palpitations, who was in the emergency department and diagnosed with anxiety. He was sent home. He saw his PCP several days later and diagnosed with ACS, which is a little bit curious to me because he didn't actually get sent to the emergency department with that diagnosis of ACS, but that was the diagnosis. The plaintiff made an allegation of misdiagnosis, which they were correct about because 3 days after they saw the PCP, the patient unfortunately died from a PE. Further exploration was the patient recently did have knee surgery. So the question that their presentation was asking us, if we had appropriate data gathering, was, with his symptoms, am I having a PE? Verdict was $1.2 million for the plaintiff, which in this state was one of the larger plaintiff cases that had, or actually in this county, one of the larger cases that had settled, because this was a rural county, which is a little bit less likely to be sued in those types of settings. Case number 2 was a 40-year-old woman with knee and leg pain. She had an examination and that was good, and she was diagnosed as having tendonitis. However, the patient unfortunately was wrong, because it turned out that the leg pain was from a DVT, which subsequently caused a PE and an adverse outcome. The allegation was misdiagnosis, failure to get a good history. And they specifically said that during the trial. The patient previously, and this was not brought up at the time, but later found that she'd previously had a syncopal episode, and she did have calf muscle pain 1 week previous. So sometimes not asking that question is the reason that we don't get that answer. And again, we are the historians. Patients sometimes give a bad history, but we are the historians. Outcome was death 1 day after their ED discharge. However, this verdict went for the defense. The final case was one that Matt Delaney and I did as part of Medical Legal Briefs on MRAP just last year. This is a 53-year-old woman with abdominal pain and hypoxemia, and she had chronic abdominal pain, had multiple abdominal surgeries, and had a recent surgery for lysis of adhesions, which unfortunately became infected, and she presented to the ED 1 week after her surgery with a purulent wound. She had not only hypotension, but also hypoxemia. And in the process of the evaluation and management, and the initial thought, which is exactly what I'd be thinking too, as far as the patient having sepsis or septic shock, the patient went into arrest and she died from what was later found on autopsy to be a saddle embolus. The allegation from the plaintiff is that PE should have been the top item on the differential diagnosis. And I hope none of us are straining our extraocular muscles and the over 1,000 people that are watching here, because I probably would be also. Of course, this was not the top item on a differential. However, is there some sort of positive thought, or is there some type of with the plaintiff, their allegation there, is this a possibility that we should have thought of that even earlier? And the answer is probably yes. However, we want to make sure that we are not just practicing standard of care medicine, but also we are practicing excellence in medicine, of course, right? So the defense says the patient was not stable for a CT, and even if we just started heparin, if we had a crystal ball, we could have envisioned that they had a PE. Well, that still would not have been helpful for a saddle embolus, and the TPA wasn't indicated until the arrest. So we'll talk about that in just a second. The point is that they defended themselves with a causation defense. And it's always better a standards defense to say we practice good medicine, as opposed to a causation defense saying, well, maybe we could have done things a little bit differently, but the patient would have died anyway. Okay, this turned out also to be a defense verdict. So very, very briefly, and I'm going to spend like 30 seconds here looking at a couple studies with PE arrest and a couple subtleties to that. The first study is by Shafiri, and they looked at just 23 patients. They found that they got ROSC in 22 out of the 23, and at follow-up, 87% were alive at an average of 22 months later, and no evidence of major bleeding even during CPR. Absolutely, we should not be giving TPA to every arrest, but if we suspect PE for some reason, it is something that is recommended both with European guidelines as well as American guidelines. So this recommendation from the European guidelines, they say that if you do give this, and I'm sorry to say this because this will make all of our lives harder, that we should continue CPR for 60 to 90 minutes after. AHA says continue it for 30 minutes after. But the point is, if we are giving TPA for this, we really do need to continue CPR for a period of time after. So what I wanted to do, and just leave a few minutes for questions, is to very, very briefly go through some of the main teaching points here. One is, and as a top 10 list, is to get a PE-focused history on our chest pain patients. So not just about ACS, but also thinking about PE, and yeah, why not dissection also, right? Thank you, George. We are the historians. So a patient that doesn't have shortness of breath might have dyspnea with exertion. A patient who's not short of breath when they're sitting in the cart might have had it when they walked into the emergency department. So asking questions specifically for that can be certainly helpful. We all know this, that normal vital signs do not rule out PE. An MDM about in patients that might be having a PE, why that is not on the differential is a good idea to do. Certainly beware of post-surgical patients. Beware of medical disease masquerading as psychiatric illness. In that first case that we presented, the patient was diagnosed with anxiety. And again, I'm sure they were anxious because they were in the active process of dying and then did subsequently die several days later. Involving the patient with shared decision-making, and a little trick with that is, in addition to putting in the medical decision-making that we've involved them, also in our discharge instructions, maybe prefacing it in this way. As we discussed with you and your significant other at the bedside, return with these specific things. So you're sort of actually doing an MDM twice, and one of them you're actually giving that MDM for the patient to see. I'll paraphrase Jeff Klein. I'll give him total credit for this in a poetic way. He says, when do we work up patients for PE? With unexplained dyspnea. It's not the 23-year-old who ran out of their inhaler who's wheezing. It's the patient who does not have an explanation for their dyspnea, or maybe even other things also, cough, chest pain, etc. Involving the family members is important to do, and making sure that the person on discharge understands what I call the third level of the chief complaint. And that third level is the fact that the patient understands that there is a diagnosis which is serious, which has not been completely 100% ruled out, and they don't go home. And as I have found in reading through depositions and trial testimony, when they sometimes ask the family member later, why didn't you go back to ED? They said, we were already there and they already ran all the tests and they told us nothing was wrong. Leaving some room for the potential of diagnostic uncertainty with the patient would be a certainly important thing, to paraphrase Steve Clucciello saying, our last chance to get it right, for the patient to return if their symptoms progress or worsen. So I'm going to stop here and I will open things up to questions if you have any. I know I sort of probably spoke right up, lean to my time there, but if there's anything people haven't, I'm happy to stick around too.
Yeah, great. Can you hear me?
Yes.
Hey, so yeah, quite a few questions came up. Sorry. One question said, I'm sorry, I don't know what's wrong with my voice. Can we use the Perk Rule?
Hopefully you're not having a PE, right?
Probably,
Atypical presentation,
maybe.
Right?
Can we use the Perk Rule for patients on beta blockers? Would that mask a fast heart rate?
That's a great question. I don't definitively know the answer for that, but I don't believe that's been studied. The Perk Rule has been looked at patients who are at high altitude and a lot of other things, and maybe it has been looked at in that way, but I do not know the answer. It's a certainly important thing to think about. I'm guessing most of our patients on beta blockers are probably over the age of 50, so we're still not going to be able to call them Perk negative, but certainly something to think about. And look, as Evie had said, if we're sort of back and forth that it still could be this after our evaluation, probably safest to default to check for the more serious thing, which could be PE.
Okay. And then the other question was, so you're saying any heart rate that is documented above 100, would that be a positive perk? And to kind of piggyback on that is that if a patient just, ran from his car to the ED or something like that, his heart rate would definitely be over 100. So how do you deal with that?
So we only have Perk negative, no Perk positive. 100 or greater means that you can't say a person is Perk negative. However, even if a person is not Perk negative, we are not obligated to do further testing on that patient. So it still would be really helpful to use all those elements of the Perk Rule, or maybe some additional data gathering that we'd want to do. Is just that we can't use the Perk Rule to rule that patient out. And I would caution against saying on a chart something like patient is Perk negative if they were 120. I would say something like the patient does not have any risk based on, some of these criteria, right? Maybe even better than that, maybe saying something like the patient initially was tachycardic because they ran into the emergency department, but if we watched them for the next 2 hours or whatever, and they've never had a heart rate of 100 or greater, all the rest of the PERK criteria are negative. And though I can't use the PERK rule to rule them out, it seems very unlikely they have PE based on these data gathering points, as well as discussion with the patient, shared decision making, et cetera. But putting that in your documentation is really important. And I know I've already said this a million times, so again, broken record alert, no PERK positive, only PERK negative. But it's still very, very helpful, even if we can't use it to rule that patient out based on the PERK rule criteria.
Got it. One comment was saying that, with the plaintiffs having retro perspective, they can see everything in retro. Yeah. He was wondering that, would circumstances such as that day being a really busy ED, or you have multiple critical patients, overcrowding, violence, does that play a role in that case or litigation? Can it help the defense?
I would say that's one of the more common questions that I'm asked. And actually, even yesterday, I did a lecture for the EM residency in South Carolina, and they asked, and we talked about that very thing, should I document that it's busy? And I flashed up a picture of the triage log that the plaintiff attorney subpoenaed, and it showed all the patients that physician had seen. And this was a patient with missed ACS who died the next day. The previous patient was an eye complaint. The previous, that was abdominal pain. There was one that was fatigue. I think there was one with depression that was just previous to that. Documenting that it's busy is very, very dangerous to do, I think, because what you're saying is that the ED was too busy for me to take good care of this patient. And look, if there's a disaster, that's going to be documented elsewhere. I don't document that, and I don't document any of those other sort of macro documentations. In the time of COVID, it's very busy and we can't do this or get appropriate testing. I'm sure your hospital would not love that documentation, but to me, it feels like a little bit of a cop-out to say, we would have taken better care of you, except for the fact that I needed to take care of all these other patients. Well, then why didn't you just have the patient wait longer? Or why didn't you call another provider in? There could be so many responses to that. If it is so busy because of a disaster situation, it will be documented in other ways, in other parts of the ED record that could be subpoenaed later. I'd be very, very cautious about that, except for maybe a few very, very special circumstances.
Okay. One listener was saying that their hospital came up with a practice guideline agreement between the ED group and the hospital group, and he wanted to hear your thoughts. So their process is basically, for a PE workup, they would document the PERK, and if the patient does not fill any of the criteria, they're done. If there is one positive on the PERK rule, they would go to the wells, and if it's one or less, they're done. Do you think that's a good practice?
Well, I think if you're not able to rule a person out on PERK, I think gathering additional data is a good idea. And look, we can all, Jeff Klein also talks about the fact that there are other situations of the patient who would, have some other reason, even though they're PERK negative, some other extraneous thing that wouldn't be part of it. So it's not meant to cover like every single scenario of every single patient. We need to use our clinical judgment in regards to that. I'm always reluctant, though, to think about like very specific pathways that we have to do it in that sort of way, because we have to be able to use our own judgment. I mean, even with the patient who has a very low heart score, there are 3 siblings just, they're twin, triplet siblings, right, just died the day before of a heart attack. It's like, even though they're low risk on the heart score, might want to be a little bit more cautious or get a second trope or whatever you might want to do for that kind of patient. So I don't know the specific data that they're basing that on. I mean, it seems like a good idea if they're not PERK negative to get additional data and to apply things in other ways. I would just try to make sure that the hospital doesn't box us in with a policy that if we deviate from, it would then be discovered later by a plaintiff attorney and brought up a trial in that way.
Sorry, I said thank you for that.
No.
There are a few more questions that I will ask you offline and then kind of turf it back to or send it back to the listeners.